You're listening to the OCD Stories podcast, hosted by me, Stuart Ralph. The OCD Stories is a podcast dedicated to raising awareness and understanding around obsessive-compulsive symptoms. I do this through interviewing inspired therapists, psychologists, and people who have experienced OCD. Welcome to the OCD Stories. And welcome to episode 420 of the podcast. And in this one, I got back on Dr. Sam Greenblatt. Sam is a licensed clinical psychologist. And in it, we discuss an update on Sam, theories on relationship OCD, the nuances of therapy, the idea of trust in your gut, a review of the therapies that have an evidence base for OCD, the need for more longitudinal research, and much more. And thank you to NoCD for supporting the podcast. NoCD offers effective and convenient therapy available in the US and outside the US. To find out more about NoCD, their therapy plans, if they currently take your insurance, or to download their free app, head to go.treatmyocd.com/the OCD stories, or the link will be in the episode description. Thank you to all of our patrons for supporting our work. To sign up to our Patreon and to check out the other benefits you'll receive as a patron, please see the link in the show notes. So thank you to Sam for his time and expertise. I appreciate it. And of course, thank you to you guys for listening as always. It means a lot. And without further ado, here is Sam. Welcome back to the show, Sam.
Hey, always good to be back.
Yeah, it's good to have you back on. And of course, I got to meet you in person October last year at the OCD Action Conference. So that was
cool. we took that little picture with our tattoo sleeves together.
Oh yeah. Oh, and the other guy. Yeah, sorry, I can't remember his name. Yeah. Anyway,
yeah, I should too.
Actually, and I actually met you at Game Changers the night before the OCD Action Conference.
Nice little speaking arrangement with Hodge's whole project.
Yeah, it was good.
Very
I
nice.
enjoy it. Very intimate. So before we get into today's topic, just an update on you. Like, what's new? What do you need to tell the people?
So big update in my life. The narrative to kind of catch any listeners up has been one of my main themes is relationship OCD. I worked through a lot of it, ended up in a relationship, it evolved into a marriage. And the update is that I learned, which is sometimes one of the most kind of triggering outcomes of somebody with our OCD, that the marriage was not the right relationship for me, and had to kind of make that decision to leave that situation. And it was a really interesting development in not just kind of my personal life, and obviously that's a huge impact and kind of a change in a lived experience, but it really made me think about my relationship OCD and the way that I had responded to it in a little bit of a different way. I think that actually when we met in person in London, you had asked me the question that is the first question that comes to like anyone's mind who ends up in a situation like that, of like, do you think that the OCD was so intense because, or maybe not even just so intense, do you think that you had the OCD because you were in the quote unquote wrong relationship, or another way of phrasing it was like the intensity. At the time I said no. I've had OCD in every relationship that I've ever been in, but through some work with, I'm always in and out of therapy, always kind of working on myself, and my clinical style is really influenced by my personal lived experience of having OCD. And therefore, a lot of the insights that I make in my personal life are ones that I really think about how to kind of formulate and conceptualize, like, how can this serve the OCD community as a whole, or enhance the work that I'm doing, enhance my understanding of the disorder. And I think that there are ways that I had been applying certain terminology that is used in very generally useful ways for OCD, almost like over applying it. And here's what I mean by that. This is a long answer to the how have you been since last we spoke, but I'm just going to dive into it. This is going back. This is I'm not really going to censor myself, and I'll just go pretty raw with it. But my path with therapy started high school, but really I would say college, the first time that I saw a therapist that really changed my life. I was experiencing severe depression, just about as bad as you can get, and all of the hallmarks of very intense depression. And just getting that baseline psychoeducation that not every thought is important, that I don't have to kind of respond or ascribe relevance to everything that my brain is saying, and especially the thoughts that were kind of careening me off into a unchecked, difficult emotional space, were thoughts that I found so much freedom and relief from being able to just allow and to let exist, but to not really indulge. This was truly life saving for me, if not just life changing for me. And it was a paradigm that I really, really went hard into. And still to this day, love has brought me so many benefits in life. I think this was doubly reinforced when I found out later on that I have OCD, went through some ACT therapy, went through some ERP therapy, and really started to drill down. Your thoughts don't necessarily mean anything. Even things that go a little further in that direction, right? When I did my postdoc with Dr. Phillipson, he would have this phrase that he meant in a tongue-in-cheek way, but he certainly repeated a few times of, I don't care about your feelings, right? And what he meant with that, with his, trademark humor, was that your emotions, to me as a clinician, are not something that I'm seeing, in certain moments or experiences as this metric that I want to track, as this thing that I want to ascribe that much kind of relevance to. Happiness trap was also something that was super influential to me. And again, helpful to me. I'm not knocking anything that I'm talking about right now. I think it's all integral. And what happiness trap, at least my interpretation of it at the time, was really about not lusting after certain quote unquote positive emotions or feelings. Instead, really being able to think in a kind of rational, logical way. What are my goals? What are my values? What's important to life? What's the type of person that I want to be? There's a lot of questions in there of like, how would I want other people to kind of perceive me? What are the qualities that I would most want to imbue? And these are the philosophies that I've really historically surrounded myself with and have served me to a really useful extent, in so many ways shaped and molded me to be the person I am, to be the clinician I am, to be the partner that I am, to be the friend that I am, et cetera, et cetera. I think that I've overutilized and misinterpreted certain nuances and aspects of the behavioral work, where in this kind of post hoc analysis of, could I have learned about like how I was feeling in this relationship sooner? Was I ignoring certain signals, which obviously I was chronically experiencing obsessions around during the relationship itself, but always ascribing a relevance to, treating it as if it's OCD. A lot of my paradigm at the time was, okay, so it's within my goals to be in a relationship, to kind of go towards this direction, to kind of commit to others. It's in my goals to always be working on myself, to not be a partner that is enmeshed and like overly concerned about like the nuances, so to speak, of who I'm with. Um, and also when it came to some of the challenges that were in the relationship and the, and some challenges within kind of the qualities of my partner, I'm not going to go into those details just for privacy's sake. Um, I had really taken it on, I think, through a misinterpretation of an act lens of it is my goals, it's within my goals and my value set to not be judgmental of different characteristics, different challenges, to make space for, differences in the relationship and, deviances or different struggles or issues or qualities that might be popping up, and instead just to make space for it, right? And on paper, all of this makes sense, right? I would say that's absolutely true. And like as a therapist, as a person, I always strive to be non-judgmental, to make space for challenges and for issues, and to have my own sense of self that is regulated and not ultimately thrown off kilter by somebody else's experience. But I think what I was doing by really first and foremost, and exclusively looking at those variables, was that I was ascribing a relevance not just to the broken alarm system of OCD going off and the sense of dread, the gut feeling that something's wrong, the chronic kind of inflammatory anxiety. But I was doing so with more quote unquote healthy, normative, um, negative emotions. I also say with quotes, of sadness or of anger or of frustration or of disappointment. I would see those also as emotions that I didn't want to ascribe relevance to, that I didn't want to own, that I wanted almost to be above. It's not, I'm experiencing some disappointment here, but it's not within my values to judge this experience. So I'm going to ascribe a relevance to this disappointment. It ultimately led me to be a little bit out of touch with information that my brain, or let's just say, my heart, was telling me about the situation, about the dynamic. And there's certainly a hypothesis worth exploring of, was my somewhat kind of suppression, or at least ignoring of these emotional signals, did that contribute to increased intensity of OCD? Was that my kind of brain screaming at me, you really do need to pay attention, you can't keep ascribing a relevance to this? I say all of this with, huge asterisks to any listeners, right? It's so funny. One of the first week that I had made the decision, I thought this is going to trigger a lot of people, like when they hear this story, right? Because again, I think regardless of whether or not there are actual issues that need to be confronted in your relationship, somebody with relationship OCD is always going to have the fear of, what if this isn't OCD? What if this is different, et cetera, et cetera, right? I would not at all see OCD, relationship OCD, regardless of the intensity level, as a sign that somebody is in a relationship that they'll ultimately understand is not the right relationship to them. I do not think that those variables are in any way consistently related to each other. But I will say that all this time I was seeing therapists that specialized in OCD. I was having other clinicians kind of check me up on this. And I think that it's a bias that I might have had, and a bias that I felt a little bit, whether intentional or not, and it could have been me as a patient more than like the clinicians that I was seeing. But this bias of, if you have OCD, let's go with that as like the primary hypothesis that all of this is just your brain and relationship OCD. And let's just work on ascribing a relevance to the signals that you fear without really spending some time examining, maybe afterwards, maybe after the inflammation has died down, but at any point during the work, really spending time to examine whether or not there is something that could be important to ascribe relevance to, right? Again, I don't think that these two variables are related, but if we're looking at that, 50% of marriages and more, far more than that of relationships end, statistically speaking, I think it's a variable that is worth looking at, perhaps a little more than some other themes such as contamination OCD, where we could really play the odds of, okay, if you haven't had unprotected sex and like needle sharing or something like that, we really don't have to spend a lot of time considering, do you have HIV now? It's a far more um, it's a far more statistically viable or likely thing that might be worth exploring. And at least my anecdotal experience might suggest that there is a trend of not respecting that nuance when it comes to some ROCD experiences. So that's what I've been kind of looking to integrate more within myself and in my work with my clients. Of not just This is not just information that I think is useful when it comes to ROCD, but it links to something that I've said before a number of times, and I straight up think that the wording might be a mistake, and I want to take it back, which is completely nullifying the phrase of trust your gut. I've spoken about it before as this is a toxic phrase. We're raised with this experience of trust your gut, and when you have OCD, you don't have it's a broken alarm system. It mimics the gut, and you should not trust your gut. You should go with your rational best guess, et cetera, et cetera. And I'm seeing OCD treatment as something that's a little more nuanced. I think that there does need to be, especially in the beginning of treatment, a suspension of trusting your gut. First couple months of treatment, don't trust your gut. Put everything on pause. We're not making any major decisions. We're going to go with some exposures. We're going to go with some max skills. We're going to really learn how to resist the urge to like analyze, is this in my gut or is this not, et cetera, et cetera. But I do think that part of what OCD kind of steals from us is our ability to have some confidence in our own decision-making process and to be attuned with ourselves and our needs. And I'm starting to see that part of the reparative experience, once you've kind of stabilized as somebody with OCD, is learning how to tell that sometimes nuanced difference between the really realistic feeling signals that OCD can send. Sometimes it's really hard to distinguish between that sense of dread and that quote unquote gut feeling that something's wrong that OCD sends us versus truly feeling that something is off. But being able to tell the difference between those two, to be more attuned with the emotional signals that your brain and your body are sending you, and to kind of repair your relationship with your gut, so to speak. I'm seeing more and more as an important and previously, at least for me, overlooked part of the journey.
Right. Yeah, thank you for sharing that. Yeah,
Yeah.
and it's great that you changed your mind on the view of trusting one's gut.
Mm.
Um, that's a whole different episode, though, I think. But just staying on ROCD as an example, like I'm glad you said that because with my clients, that's something I've been thinking about uh, for a little while now. That um, I mean, I'm integratively trained, so I'm always thinking or even bringing psychodynamic principles in my mind. I'm not necessarily bringing it in with the clients, but how I think about a case. And then the
Mm.
treatment is still ACT, ERP, compassion focused therapy, but I'm formalizing in a different way to try and understand, as you're saying, the nuances. Do I get it right? Not always, but I guess I bring that up thinking about RSDs. We've got to bring in attachment theory and think, for
Mm.
example, like someone's attachment style if they're naturally or like you know let's say dad was always absent in my life. He wasn't, but let's hypothetically he was, and I loved my dad and I really just wanted him to be there, but he was never quite there for me. Now when I'm in a relationship, a loving relationship, maybe it's the right relationship, but my partner is doing something that's triggering that feeling in me of abandonment. If I've naturally got OCD and anxiety, what feels like a bit of letdown now becomes this massive thing that my brain can obsess over. So I guess I'm bringing that up just as one example of, as you're saying, maybe it doesn't signal that it's the wrong relationship. Obviously, it might do for some, but most maybe not. But it might signal that there's something in the relationship that needs seeing to and needs working on. And that's where, like, because none of us are in perfect relationships, they all require work. And if
Yeah.
our attachment styles are a bit off, so to speak, it's not the right way of saying it, but if they are, then our OCD's got so much more content to latch onto. And it doesn't mean we're on the wrong relationship. It just means we need to communicate with our partner our needs better and get those needs met. And when those needs met, our brain may not be as triggered. And that's
Mm.
obviously like emotion focused therapy, which is for couples, imago therapy is for couples. They all look at that attachment and the past history and understanding each other's triggers in the relationship. So with someone with OCD, those triggers become this is the wrong relationship instead of those triggers are signposts to something that may need attention and healing. That's
And
just
I
my
think what you're
working
saying,
theory. Yeah.
yeah, 100%. There's absolutely room for that within that theory. I think what you're adding to the conversation here is that it's a whole spectrum of options, and
Oh yeah.
all of which are viable and possible and worth exploring, right?
Mhm.
It could be, okay, so you have relationship OCD, you know this is really a you thing or your brain thing. The relationship really checks out, and we just got to work on you.
Yeah.
It could be, oh, this is not, this is a very viable relationship, but because of things that are, neither person's faults, there's some things within the interpersonal dynamic that could be improved through
Mhm.
you and I, the patient and the clinician, um, further exploring things, and then maybe bringing in the partner and literally working through things in order to improve the relationship. And we got to work on some of your OCD.
Mhm.
And it could be a third option. It could be, yeah, there you have some OCD and a broken alarm system, but a lot of it is covering up that there are some real issues in the relationship, and we really need to examine whether or not those real issues could or should be worked on.
Yeah. That's it. There's nuance and a million
Always
outcomes.
nuance. Always
Yeah,
nuance.
that's it. Well, that's
Yes.
where CBT's failed a lot over the years. At least initially, it wasn't nuanced. At least in my opinion, I could be wrong
Yeah.
there.
No, you're right. You're absolutely right.
And not to discredit CBT, it's wonderful, and ERP is a part of that. But it's got to be taken off that pedestal and integrated with other things for nuance.
Yeah, if we look at like the research behind the ERP and the ERP, like, treatment based protocols, right? It's 16 sessions, and you're really starting off with like, okay, session one, psychoeducation around this is OCD, and this is what our treatment plan is going to be, right? So session one, you already have the treatment, you're already explaining this is my conclusion about you,
Mm.
and this is what we're going to do for the next 16 sessions in order to treat it, right?
Yeah.
There's not that room for that nuance and for that kind of individual kind of curtailing of treatment. And that's where like there's pros and cons to it, right? When you have kind of the organizations or like whether it's a hospital setting or it's a more kind of mass produced kind of version of therapy in general, um, it can kind of widely spread a lot of that benefit of CBT to a really wide audience really quickly. And naturally, the greater that you kind of expand something and make it this kind of cookie cutter approach, the more folks might end up falling through the cracks.
Yeah.
So there's the
That's,
nuance there too, where this approach, if administered in a standard way, that is the way to benefit the maximum amount of people, for sure.
Mhm.
Um, and not everyone.
Yeah. True. True. Um, so look, that kind of leads us on to the topic of today, and the topic of today isn't ROCD. It's you've taken the time and looked at all the research for the different therapies for OCD. So yeah, just where do you want to start with that? How do you want to begin?
So it's not. It's this is. I'm going to present a bit of information, and I'm trying to think about how not to make it so dry because I think that there's a really interesting potential point here. Um, my take might be a little warm to hot when I'm coming out with this, but I want all of this to kind of have the addendum to it that this is a take that I have based upon my research, and this is a hypothesis, but this is nothing that has been kind of verified.
Yeah,
Take it,
it's
leave it
not a
as you will.
peer-reviewed meta-analysis, right?
Exactly, exactly. This is the clinician spending too much time on Google Scholar and organizing some information here. Um, but the search for what forms of therapy have what degree of evidence has really come from questions that I as a clinician kind of frequently get. I'll always get emails of hey, what are your thoughts on X, Y, Z? There's so many different
Yeah.
emerging treatments for OCD that have either been kind of developed within the last few years or have some more long-standing kind of support behind them, but folks are still skeptical around. Um, and I found that the really big difference is the difference in treatments for OCD that have longitudinal evidence versus those that don't. And what we mean by longitudinal evidence is a lot of times when something is shown to be an evidence-based treatment, um, the way that those studies work is that they administer the treatment protocol to, a sample size. Um, they measure before, okay, what are your OCD levels? They measure maybe immediately after. And then after that, sometimes there's something like a 3-month follow-up. They measure the symptoms like 3 months later.
Hmm.
But a lot of times it's there's no 3-month follow-up and you're just kind of measuring, let's take that 16-week protocol example that I gave. You're measuring at session 1 and then you're measuring at the end of session 16. So, 16 weeks later. If the scores are dramatically different from session 1 to session 16, then it's considered, and that's replicated enough times, then generally that gives it enough to consider it kind of an evidence-based treatment. What I found is there's a good number of treatments that do have the that short-term effectiveness, right? Cognitive therapy has been compared to exposure and response prevention a number of times, has been shown to be equally beneficial. There's some studies that's not as beneficial, some studies that's more beneficial, but in general, like these things called like meta-analyses that look at, it's a study that looks like at a bunch of studies, found it, equally effective. ICBT, which is kind of a relatively newer kind of treatment protocol, has also been found effective for OCD. There's that one study that they like to talk about a lot where it was found to be more effective for people with more highly overvalued ideation, folks that are a little less skeptical of the kind of intrusive thoughts that they're experiencing. I think that there's only one study that has found that, though, to my knowledge, which also as kind of this like intro to research one-on-one for any of the listeners. One study alone can be seen as like maybe a promising sign, and even though there are a lot of statistical procedures that are done to make it so that you could try to make a conclusion from a single study, it's certainly better than a random chance outcome. Usually, if you want to feel really confident about something, that study needs to be replicated a number of times, and then somebody does a meta-analysis where they look at 10 different studies. They find the results aggregated from those 10 different studies, and when that finds results, that's when you could really feel a lot more confident in concluding whether or not something was useful. So with ICBT, to my knowledge, there have been no meta-analyses, but there have been some well-designed trials that have compared it to ERP and found at least some similar effectiveness. And with ERP is very easy to measure in that way. It's been well studied for a very long period of time. ACT as well has a very good number of studies behind it. The difference between every form of therapy that I've found versus exposure and response prevention, to my knowledge, and looking at my notes, actually, I'll only give a 50% chance of confidence around there not being a longitudinal study around ACT, but I'm fairly confident around that. No other studies have had longitudinal research conducted around the effectiveness, or rather, no other studies have published any kind of outcomes. The reason that I say published, and this is where it gets way more about, this is a potential hypothesis, but take this sentence with more of a grain of salt than any other sentence they'll say, in this episode, is that there's a well-known bias in research called the publication bias, or the file drawer problem. And what that means is, generally speaking, studies that have significant results, that have found, okay, this treatment works in this situation or over this period of time, are far more likely to be published than studies with insignificant results. It's sexier, it's more interesting. People really want to know what works, and they're far more interested in that information than learning what doesn't work. Does this mean that we could kind of read between the lines and assume that there have been studies that have found non-effectiveness of longitudinal kind of research behind non-ERP treatments for OCD? That is the thing that, that's the whole grain of salt, who knows or not. But it can be stated with some decent confidence. I spent, a few months kind of trawling through, even message some of the kind of leads in some of these kind of research in some of these treatment modalities, and asking, have I missed anything? Are there any like longitudinal studies? And even with that kind of expert consultation, it can likely be concluded that outside of exposure and response prevention, these treatment protocols have not been proven for long term. Now I get into more hypothesis guessing and my kind of hot take, which is perhaps an explanation for this is that some of the other treatment modalities, the therapeutic agents behind them, is a sophisticated form of reassurance that might wear off over time. it's something that I've struggled a lot when it comes to cognitive therapy. And a lot of other clinicians that I speak to also can't really wrap their heads around what are the components of like traditional cognitive therapy, which is about challenging the evidence behind these thoughts and reaching a more logical conclusion that is uniquely different from ruminating. But the fact is that it has been proven to be effective. I wonder, and I would love to see any studies challenging this. This is just maybe a call to the research community at large to challenge or to disprove this hypothesis or this possibility. If seeing a expert clinician who seems very confident and talking about a specific theme and getting kind of that expert influenced kind of conclusion drilled down over and over mimics treatment outcomes with OCD over a short period of time, right? Because what we're measuring is how much time are you spending obsessing and compulsing? And we know everyone who has OCD has known that at different points in their life, they've had a huge theme, gotten some real juicy reassurance, or had a quote unquote insight. They had this awakening kind of moment or experience where everything kind of clicked. And it's had effects that have lasted, a few months. It's very rare, and that's the addicted kind of part of it. We just want that to last, and we want to kind of pursue it. But I think with OCD more so than other diagnoses, it's really important to hold ourselves to the standard of longitudinal outcomes, not measuring outcomes within a short period of time, because OCD can absolutely have these false positives over a short period of time from ways that would not at all predict that their OCD has been treated, quote unquote.
Yeah.
Those are some initial. I have another batch of information, but I'll pause there, and I'm curious as to what your thoughts are.
Yeah, I mean that was a good place to start, and obviously ICBT is getting a lot of attention at the minute, so it was good to kind of cover that from the research side of things. And like ACT, when I did my first master's in mental health in 2018, 2017, 2018. As part of my dissertation, I did a systematic review of ACT only trials for OCD, so that where they hadn't used ERP, just ACT as a sole frontline intervention. At the time, there were like 7 studies. I think there was either like 1 randomized controlled trial or none. The rest were non-concurrent multiple baseline trials. So they did it with like 6 people.
And for the listener, a randomized controlled trial is the gold standard treatment.
Yeah.
There's different levels that you could kind of try to make a conclusion. There's a non-RCT, non-randomized controlled trial, it's very hard to make any sort of real conclusion off of that. There's an RCT, and that is the gold standard. There's an increased chance that your conclusion is correct. And then there's a meta-analysis of RCTs, and you can be very confident. I'm sorry to cut you off.
No. So that was really worth explaining. And as I say that, it might have been 3 RCTs, but either way, compared to ERP's amount of RCTs, it's very, very small. But obviously, ACT research started a lot later than the ERP. But anyway, what I found was, again, take it with a pinch of salt because it wasn't all randomized control trials. In those studies, sometimes they compared it to ERP, and looking at other ERP randomized control trials, the outcome effectiveness was as good as ACT as a sole intervention, but you have to take it as a pinch of salt because it wasn't RCTs mainly. And I know because I replicated what Michael Tuhig did about 4 years earlier, and I didn't publish it because I found exactly the same as what he did. There's been way more ACT studies now for OCD, I think, including ACT and ERP together. But I just wanted to bring that in and I think it's worth saying, like, obviously, like I said, I'm integrative. You are, most therapists are, to be honest, to varying degrees. And I bring in compassion focused therapy, acceptance commitment therapy, but to prove the effectiveness of ACT, you need to test it as a sole intervention before saying it's
Mm.
evidence based for OCD. Even though you might only ever want to merge it with ERP, you have to test it standalone. And I think that comes up with, I interviewed 2 years ago, Nicola from Italy, I think he's from Italy. He was doing a trial on compassion focused therapy or compassion focused group therapy for OCD. And there was some effectiveness to it. It wasn't revolutionary, but there was some effectiveness. And I think they said there was another study in the works as well. So who knows how many CFT studies there are now, but maybe you do, Sam. But just to say, there's studies being done all the time on all these other
Right.
maybe fringe therapies for OCD that maybe in 10 years from now may have really good cases for them, but currently are early stages, like EMDR as well, right? As
Yeah, I
far,
think EMDR is such a
yeah,
great example of chasing the hot new thing. I mean, EMDR is not
yeah,
new anymore, but that kind of classic example of with EMDR when it came out, it was the new thing, and oh my God, I need EMDR. Are you specialized in EMDR? Do you have the equipment, et cetera, et cetera? EMDR is an evidence-based treatment, right? It's well documented, and when they did a component analysis of EMDR, EMDR is this form of therapy where I'm going to explain this in a really kind of brutally non-complex kind of way, but um, it integrates this kind of machinery that you're supposed to look at that has this effect on kind of where your eyes are directed while you're recounting something that provokes anxiety, oftentimes trauma. And it has some kind of that's kind of the way that the therapy is conducted.
mm,
And when they did a component analysis of it, and they took out the machinery, it was shown to be just as effective as with the machinery. And the machinery was that really
yeah,
attractive, exciting thing to people. But it turns out that without the machinery, it's exposure therapy.
yeah,
What you're doing is you're recounting, you're talking about what is distressing to you, and it's a great lesson that it is amazing that all of these new therapies are coming out. We need, we innovation is great and it is important. And the reason for me doing all of this research is as kind of reaction formation to people being so curious about the hot new thing. And maybe this is the thing that can change and I can jump onto that. And if you've tried everything else and you really feel like you've exhausted your results, or if that's just your style, 100% go for it. But I think that it's important to realize the comparable amount of evidence base that is behind
mm,
the different treatment modalities and the amount of security that you might be able to feel in getting effective treatment just based off of the literature alone, if that's the type of way that you like to make decisions.
yeah, good point. And I think that you've highlighted there a weakness of RCTs, though, which is one of my biggest criticisms of them, is they
Mm.
tell you if something's effective, but they don't tell you why it's effective.
Mm.
So there, EMDR is effective for some cases. Not saying it's
Right.
effective for OCD, but for some things it definitely is. But there you're saying, and what it's a very controversial topic, that actually what makes it effective is the exposure element of it.
Right.
That's the argument out there. Obviously, EMDR therapists will debate that, and that's okay. But that is the argument within therapy circles currently. And RCT would never have highlighted that unless there
Right.
was maybe qualitative interviews as well alongside the RCT of what did you find useful? Actually, I was just sharing my story in a compassionate
Mm.
environment, like um but yeah, which is why for me we need RCTs, but there needs to be other studies alongside that to figure out what's the change
100%.
mechanism. Yeah.
100%. What's the mechanism of change? Yes, and in these situations, is the mechanism of change like reassurance, like
Mm.
almost that could be solved through kind of a component analysis, but it could also be proven through longitudinal information. If it's
Mm.
reassurance, then it's not going to last. The effects of therapy are not going to last more than a few months. If it's reassurance and you measure a year later, or if it's not reassurance and you measure a year later, the therapy should still be working. But if it is reassurance and you measure a year later, there's probably not a great chance that you're still experiencing those results. And that's the last thing that I wanted to squeeze in here, because I know that we're a little low on time. Is that is two things. One, yes, ERP has some great evidence in terms of its long-term results. The results really seem to last. It was one study that I found reduced things by 40, reduced kind of Y-box, like the intensity of OCD by 41% on average, and at a 7-year follow-up, it remained reduced by 45% on average. So it even kind of increased. One important part about all of this that really throws kind of a wrench in even maybe kind of the premise of should a good therapy last is with a lot of these follow-up studies. And I found one meta-analysis that found like 21 long-term follow-up studies after ERP was conducted. So there's a lot. There's a good amount of evidence. But it also found that nearly 77% of patients, or 77%, nearly all patients, have received additional treatments throughout the follow-up period, right? So they are folks that are checking back in. Then the question is, can we optimize that even further? And I found this study that like Edna Foer herself, like the creator of like exposure therapy, implemented that. I don't know if it got kind of lost to time. I don't know why it's not like more focused on, but she came up with like a relapse prevention program of 4 90-minute sessions over like a 1-week period after some evidence-based protocol. And it found that it was hugely useful, that it was an 87.5% of the relapse prevention group remained improved at follow-up compared to 50% of the group that didn't do so. What this stresses, and this is kind of, I'll always mention and ship like the inhibitory learning model of exposure and response prevention, which I see as the more updated and potentially more effective kind of model, is that building into therapy ways that you can view this experience as a set of skills that can be applied to your OCD, no matter how it manifests and no matter how it pops up, which is what FOA. This was the kind of a component of FOA's relapse prevention group, was kind of building up these skills in yourself. Imbuing a client with that ability to treat their own OCD, I think it's so integral and important. And it's something that newer model of exposure and response prevention, I think, addresses far better than the habituation model, which was more go to the other episodes because we don't have time to go into it here, but which is more about, okay, I'm the clinician, I'm going to treat you, I'm going to design this protocol so that your OCD kind of goes away and you habituate to it, to I'm going to help you learn how to respond to your signals differently. And I always say to my clients, my goal by the end of our work together is to be completely useless to you. I want you to have all the knowledge and expertise that I do. Building that into ERP, I think, can extend the benefits even further. And that's really the standard that we should be holding treatment to. Not will you feel better by the end of therapy, but will this be a fix that could last a long period of time?
Yeah, it's the cliche saying of give the man a fish he eats for a day, teach the man how to fish he eats for a lifetime.
100%.
Yeah. Yeah, and that's the way I was taught CBT. It was communicated to me, the goal was by the end of this, they're almost their own therapists.
Yeah.
And I do like that viewpoint.
Yeah. I think that the theme of the day maybe is that a lot of these axioms are known to be true, but it's not how a lot of therapy plays out.
No, good point. Yeah, and then just on the research. There are obviously many therapies we haven't talked about that probably have some studies for OCD, but it's not
Sure.
enough that we've talked about them.
Right. If I haven't mentioned it, then it has maybe even less, evidence based than I would say cognitive therapy, ACT, exposure and response prevention. Those are probably like the three that have been the researched the most when it comes to ERP. And then you were mentioning compassion focus. We were talking about like ICBT. There's a lot of different things. Greenberg is hypothesizing his like psychodynamic kind of approach. There's a lot of different like relatively smaller scale or newer things that we haven't brought up because they haven't existed for decades. They're even more kind of fledgling and figuring out the degree to which they're evidence based than the ones we mentioned.
Yeah, and of course, and then there's like, I've got, as we do this podcast, to the left of me is my sand tray. So I do sand play therapy with some of my clients, more so with the non-OCD clients, but sometimes with the OCD clients. And you can integrate exposure with it. But the reason I bring that up is I was curious about the evidence base. Has anyone studied OCD? And I found one study out of Brazil that did it on 3 kids, and the treatment lasted 2.5 years, but the Y box went subclinical on all 3. Now you can't.
Oh, wow.
Yeah, it's amazing. But again, there's so many factors you need to factor in to see if that's reliable.
Right.
It's not an RCT, but that's a very Jungian based therapy. It's all about symbolism and but it gets to say that you could almost Google any therapy and I'm sure you could find, and sand play was developed in like the 60s or something. So
yeah.
Even in old therapies that typically aren't evidence-based, especially psychodynamic ones, they may be 1 or 2 studies, but it doesn't mean they're effective.
Right.
But you can always find probably a study for something.
It doesn't mean they are, doesn't mean it's not.
No, exactly.
I think the underscore is
it's unknown.
Yeah. If something has like 1 or 2 studies, that's probably not great evidence in either direction.
No.
That you could conclude over.
Yeah, exactly that. Yeah, and that's to say if your therapist is as long as they're using evidence-based therapies, I would say it's okay within reason that they're using non-evidence-based therapies in coordination. Like I said, I use sand play. There's no strong evidence base for it, but I actually see it moves people in quite big ways sometimes. But of course, I'm still using ERP and ACT and CFT.
Yeah, and honestly, actually, there's evidence based to that component too. The evidence for therapy overall has found that I'm going to use some big words and then I'm going to simplify it. That there's a curvilinear relationship between flexibility and fidelity, which means that if you are overly rigid to a treatment protocol, if you're doing that 16-week, here's your kind of application of ERP, sir or ma'am, it's not going to be optimally effective. And if you're totally off kilter and you're just saying, I'm going to do my own thing, I haven't read the evidence or I'm ignoring it, and we're just going to go and feel things out and see what happens, it's also not going to be optimally effective. But it is somewhere in the middle where you are basing your work around things that are evidence-based, but you're also curtailing it to your personal style, your client's personal style, the integration between like what matches between you two. That yields the most effective results.
Yeah, look, we end where we begin with nuance, right? That's effectively what you're saying there, right? Yeah. Or fluidity, not rigidity.
We love fluidity. We love that nuance.
Yeah, it's fluidity within a nice container. So it's held, but there's movement in there. It's not a river that's going everywhere, has no boundaries, no rules and regulations.
Exactly. I think another metaphor that comes to mind is, even a jazz musician needs to tune their instruments, right? You need the strings tuned to the right degree. You need kind of that rigidity there in order to play around with things and to make that beautiful music.
Yeah, good point. I like that. So look, I guess lastly, is there anything else you wish you could have said or shared today?
I think I got it all out. I feel like I just talked for an hour straight, but I think I squeezed it all in there.
Nice. Nice. I
Yeah,
like
no
it.
other thoughts. That's everything I know about OCD.
Good. Well, I'm sure it's going to resonate with people. Maybe ruffled some therapist feathers, but that's always good.
Sure.
Um, and yeah, thank you as always for coming on and sharing.
Total pleasure. Always a pleasure. Thanks for having me.
Thank you for listening to this week's podcast. And thank you to our Patreons who helped make this episode possible. And if you would like to find out more about Patreon and the rewards and benefits, then there will be a link in the episode description. If you enjoy the OCD Stories podcast and would like to support us with a one-time tip/donation, please go to theocdstories.com/support. All tips, no matter how large or small, are greatly appreciated. Please subscribe and rate the show wherever you listen to the podcast. And thank you to NoCD for supporting our work. And if you want to find out more about NoCD, head to go.treatmyocd.com/theOCD stories or click the link in the episode description. And quick disclaimer, guys, this podcast is not therapy. It is not a replacement for therapy. Please seek treatment from a trained professional. And until we speak, take care.